And I'm going to start recording so I don't forget that. Dr. Bennett, you should be able to unmute yourself.
Good afternoon. Good afternoon and welcome to COVID Conversations. This series is designed to be a year-long approach to an interdisciplinary conversation surrounding the COVID-19 pandemic. It features campus experts who will address the pandemic from their field of expertise each week. Each session will start with a talk of approximately 20 to 30 minutes and then be followed by a question and answer discussion session. Now, I would like to introduce our first speaker, Dr. Andrew Callinger-Yoke from the Department of Biology and Earth Science. He will be talking about epidemiology and its connection to COVID-19. Thank you, Dr. Yoke.
Hi, everybody. I hope you can hear me. If there's any audio problems that happen throughout this, you can just reload the Zoom and you should be okay. I am a disease ecologist. I work mostly with animal systems, but there's not that big of a difference. We're all kind of one and the same. So a lot of the same terms apply across the field. So I'm going to be talking about the general background of epidemiology and then particularly specifically the epidemiology of COVID-19, also called SARS-CoV-2. It's a virus that causes the disease. These are today's current numbers. This is from the COVID tracking project. We're at just shy of 180,000 and just past 6 million cases. So this is probably going to change, but this is just kind of date to the slide. The first term that we have to understand when we're talking about an infectious pathogen is we have to understand R naught. It says R0, but it's pronounced naught. It's the British. The R naught value is this kind of inherent value to a particular pathogen that tells us how many new infections that it's going to generate when it enters into a new population. So everybody in the population has to be susceptible to it. We can't compare R naughts unless we're actually talking about a truly susceptible population. COVID-19 has somewhere between a 2 and 6. The best evidence right now is from some studies that were coming out of Wuhan that put it at probably somewhere around a 5.7. Well, what does that actually mean, right? Different pathogens have different R naughts. If we're talking about something like rabies, which is what I work on, rabies has somewhere around like a 1.2, 1.3. The flu has anywhere from like a 1.5 to a 2.5 in any given year. Something like measles has an R naught of 18. Well, what does that R naught actually tell us? If we have an infected person, during the course of that person's infection, on average, right, it's not a hard and fast rule, but on average, that person is going to infect 5.7 new people. Each individual case will generate 5.7 new cases. Then those 5.7 new cases will also generate somewhere around 5.7 new cases. And then all of a sudden, in a fairly short amount of time, we went from 1 to 32. That's a pretty big and rapid increase. One of the reasons why we saw exponential growth at the beginning of the infection, where you started to see areas that basically had no infection, and all of a sudden it's a burning fire of infection in a locality. The important thing about R naught to understand is R naught is only when we're talking about a uninfected population and when you're not trying to mitigate disease at all. We can actually change the current reproductive value, that R value, by doing things like staying home, wearing a mask, keeping a 6-foot distance, washing your hands fairly often, not touching your face, right? These are all great ways to interrupt the chain of infection. When we're doing this, we can actually pull R naught down, right? This is Ohio's R naught all the way back to the beginning of March, right? So right when everything started to shut down around Ohio, we were estimating that the R naught was somewhere around a 2.5 to 3, right? So a pretty high R naught, not as high as it was initially in Wuhan, But even before this in March, we were still changing our practices a little bit, which is why we weren't all the way sky high up at like 5.5. Now, if we've changed and pulled R naught down, now we're talking about RT, the reproductive number at each individual time t, right? So you can see when things started to go south in late March, right? We initiated a shelter-in-place order in Ohio, and that brought our R naught value down below 1, which is great. That's what we want to have happen. But when we started reopening, right? Businesses started to open back up, non-essential businesses opening, the shelter-in-place order ended, and pretty quickly, we came back up over a R naught of 1, right? So our R naught value peaked back up to about 1.2 or so. It's still steady for the next, hold on one second, a battery issue. Apology. So it's held steady at about a 0.94 for the last few months, right? So this is right where we want it to be under 1. We want the infection rate to be going down. Unfortunately, there's some evidence in the last few weeks, right? You can see the possible ranges actually start getting a little bit larger, right? Because there's delays in reporting and delays in when symptoms are appearing in people, right? So there's some evidence that we might be picking back up as a possibility. If we have an RT below 1, that's great, because that means that each time an infection is generated, that new infection is going to generate less than 1, right? So eventually, this is going to burn out all on its own. This is a good thing. We want our infection rate to be below 1. 1 is our magic number here. And as you can see, Arizona had actually had a very similar graph, right? They had a relatively high RT. They tamped their infection rate down by sheltering. And then as they started to unshelter in place and reopen the state again, the R naught creeped back up. You might be familiar with the fact that Arizona was having one of the worst infections at the time of about July 1st. But you can see it would actually had a good R naught, or I'm sorry, an RT. We had under 1. So why is that the case? Well, RT doesn't tell us that whether the infection is bad or good. It tells us whether or not it's getting worse or getting better. So an RT below 1 means that the infection rate is getting better, but that happens to correspond to when we had a lot of cases already. Arizona in July 1st was reporting 4,800 new cases every single day. If we have an RT of 0.94, each one of those cases is only going to generate 0.94 cases. But when you have a big number and you multiply that big number by 0.94, you're still left with a big number. It's still 48 or 4,600 cases. That's still a lot of new people getting sick. So we really, when we're tracking RT, we have to be careful about sustaining and keeping RT below 1 over a long period of time. You might notice that this is Ohio's new cases graph over time. This new cases graph, starting in July or so, continued to creep up, right? It tracks with this data that you're seeing here. And then you started to see some declines and then a little bit of a blip of an increase, right? The only way it's not a flat line, right? We don't see a collapse in early June because we still had big numbers, and those big numbers are just getting slightly smaller, a little bit slowly though, right? It takes time for a reduction in the R number to bring these values actually down. The other thing that we need to keep in mind is we need to keep in mind herd immunity. Herd immunity has come up in the news a lot lately as a potential savior for us to try and to get out of this pandemic in the US. That's a really, really, really bad idea. The reason for that, to achieve some sort of sufficient number of people that have immunity against this, you have to be sure that individuals can be immune. There's no evidence for that right now. It's likely, but there's no evidence. And to get to something like 70% of the population being immune currently 70% of the population would have had to gone through infection. And that's going to be okay for most individuals. Most individuals make it through this, but 70% of the United States, if 1 or 2% of those people die, that's millions and millions of people, right? You can see how this actually works in practice when we're talking about how these kind of infectious disease models would work. This is just an example. This is someone that, I didn't make this one, but someone else did. This is just a blue population of people, and then there's red individuals, and a similar parameterization to what we see with COVID-19. If we run this forward in time, you can see that the infection rate, we're going to have a lot of people getting sick. That infection will spread, and these red individuals will eventually convert to gray, as in they are now immune again. And the problem with this is, you can see on this, on the graph that we have right here, this orange line is actually our healthcare capacity. So as we start to have high numbers of people get sick, even if they're not getting sick to the point that it would have killed them if they were able to receive proper care, if we have more patients than we have beds, care rationing can increase mortality rate. So if we set this up again and we reduce the transmission rate, right? We cut our R value down. We make it so that less and less individuals ever get sick. This is the whole idea behind flattening the curve, right? We never have more individuals that are sick, this red line that you're seeing right here. We always have fewer sick people than we have healthcare capacity. This is what we're trying to do in real time. We're trying to bend the curve of this infection down so that we never outpace our capacity for care. Why are we carrying about 6 feet, right? A virus is attempting to get from person to person. Lots of viruses employ different strategies. They're going to do things like hepatitis, or it's going to go fecal oral. So this is why you want to wash your hands after you're going to the bathroom. HIV and HPV commonly use sexual transmission. COVID-19 and influenza both use a similar pathway called droplet transmission. This is just a tool that this virus is using to get into a new person. That's the whole strategy of a virus, is to jump from person to person as effectively as it can. When we talk about droplets, what we're really talking about is we're talking about the water vapor that's coming out of our lungs. Every time you breathe, every time you talk, a lot when you sneeze or cough, a lot when you sing, right? A ton of these water droplets are coming out. Excuse me. These water droplets are going to be leaving your lungs and traveling some bit of distance. Big water droplets that generally contain lots and lots of virus are going to be pulled down faster. Again, it's relative. And when these large water droplets are going to be terminating early, they're not going to reach a person that's 20 feet away. When we're talking about these smaller water droplets, the smaller water droplets that are smaller and inherently contain less virus, those are actually able to jump a little bit further, right? That they're less risky. That's why we have this kind of barrier of danger around someone that potentially is infected. You've in the news recently seen stuff about like things being airborne or persisting in environments, especially indoor environments. The reason for that is there are some small amounts of really tiny water droplets that are coming out of our lungs, especially when you're doing stuff like yelling or singing really loudly, that can produce a lot of these water droplets. And if you're doing things like medical treatments, like pulling out a tube or intubating someone when they're trying to save someone's life by giving them the ability to breathe, that produces a ton of these really, really tiny water droplets called aerosols. Those water droplets are actually able to float slowly down to the floor so that they can persist in the environment for a really long period of time. You can kind of think about this as like a cannon, right? If I have a cannon here, right? And I put a big giant cannonball, that cannonball is going to fall relatively short, right? It's not going to be able to go too far to cause it to spread its contents. If I'm using really, really tiny cannonballs, those cannonballs are able to last longer. And maybe if we're using really, really small cannonballs, they're able to just float in the air rather than ever falling, right? So it can take hours and hours for some of these small water droplets to actually escape. Fomites are another concern. We think that it's actually not a terribly big concern for COVID. It tends not to be very stable in the environment. Yes, you've seen a lot of studies where, like, you can see library books can have infectious pathogen on them after several days, but there's really not a lot of it, and we don't actually think that's a very common pathway for people to become sick with COVID-19. The reason why COVID-19 is much, much worse than the original SARS outbreak that happened a few years ago, SARS-CoV-2 is very, very similarly related to the original SARS outbreak, but a big difference is a lot more individuals that get sick with COVID-19 don't display symptoms, right? They're asymptomatic. So if I don't feel bad, I'm going to go into work, I'm going to go to the grocery store, I'm not going to wash my hands as much, right? Because there's no reason that I would think so. And you can actually see there's big differences in the types of populations that are actually asymptomatic. Really two things that I'll point to, right? Where you have relatively high asymptomatic percentages, right? Are generally young, healthy people, right? Of working age, right? That are otherwise not particularly sick. People that are, especially for the data that came out of King County, right? Places like the King County nursing facilities residents, like people that are geriatric, that are already of quite old, they're generally not going to be asymptomatic. So this pathogen seems to be one that is spreading a lot in people that aren't aware that they're actually sick. So if you go to class and you're unaware, especially if you're one of these younger individuals, you may have a 60, 70% chance of not actually showing any symptoms at all, or very just mild symptoms. So that is where we actually are getting a lot of spread. And you can see that in some of the median age of the people that are becoming infected over time. This is why, no matter or not you think you're sick, right, whether or not you've had exposures, this is why masks are one of the best public health tools that we have to stop the spread of infection. This is going to be something that doesn't stop infection entirely. There's been a lot of studies that have been coming out now about people that different types of masks that have different abilities to interrupt transmission. But really all we're trying to do, I don't need an N95 mask. I don't need a surgical level of protection. Even if I'm using a piece of cloth that has been folded over twice, all we're really trying to do is we're trying to catch those big giant droplets that carry a lot of virus. And it doesn't have to be a perfect system to just bring that transmission rate down. Additionally, probably one of the best reasons why you should wear a mask is not only you'll make people around you you won't get them sick, but there is some evidence that if you are wearing a mask, you are less likely to get sick yourself because that mask prevents a little bit of virion from entering into your lungs. And even if you do get sick, even if a little bit of that virus does make its way into your eyes, your nose, your mouth, that virus, the smaller amount of virus that gets in means that when you do get an infection, you're not going to get as sick. You're much more likely to be asymptomatic. You're much more likely to not end up going to the hospital because of COVID. So there is evidence that it is good for you to wear a mask. This is unfortunately stuff that in the beginning of the outbreak, even like US government officials were unfortunately wrong about a lot of stuff, right? This is US Surgeon General telling you not to wear a mask and not to use N95s. And that mostly had to do with the fact that we didn't have capacity at the beginning of the infection. This was a mistake, right? To make really broad sweeping statements that you don't have the evidence to back up. But at the time, we didn't think that masks were an effective treatment because that wasn't a really big deal for the original SARS virus. Science changes, the evidence that is being presented changes, and then we actually change and alter our behaviors based on the new evidence. That's what science is supposed to be about. It's okay if we're wrong initially. we change and modify and get better at this. Something that's also been in the news relatively recently is the sensitivity or specificity of a test that you're getting. And there's actually a bunch of different kinds of COVID-19 tests that are out there. The one on the left you're seeing is probably going to be used for a PCR test. You can actually get a blood test. There's rapid antigen tests that we're going to be talking about, the thing on the right. Whatever type that you're getting, each test for anything, whether we're talking about COVID or flu or rabies, all uses the same sorts of terms. So I wanted to highlight what sensitivity means and what specificity means, because I've actually seen this used in really inappropriate ways when people are talking about testing. So if we have a population of people and these people are intermixed and there's some people that are infected and some people that aren't infected, our job is to try and parse out who is actually sick and who's not. So if we know with perfect information about who is sick, we can actually just label all the sick people and label all the people that aren't sick. But we don't have that. We have to use these testing procedures. So if I were to have all of the green people and all of the blue healthy people, if I test everybody with my test, and the test tells me that these people are sick, right? The red circle, everybody in that red circle gets a positive result from a test. That's a bad test, right? We want everybody that's green to show up as sick, and I want no people that are healthy to not show up as sick. So the reason behind the problem with this is tests aren't perfect. Tests operate on detecting virus or they're detecting an antigen. And so we have to actually test and measure the efficacy of some of these procedures that we use for picking up infection. Test sensitivity is the first one and probably one of the more important ones. A test sensitivity, if I test a sick person, does that test say that they're sick? That is all test sensitivity tells me. So what that effectively means is I take the people in that center red circle, semicircle, the people that are sick and that the test says are sick, and I divide it by all the people that are actually sick. So what that actually means for this test, if you run a little bit of the math, is 5 divided by 11 is 45%. That's a pretty bad sensitivity, and it's not actually what we see with COVID, fortunately. When we're talking about COVID-19, most of the tests, PCR, polymerase chain reaction tests that use reverse transcriptase, are really, really sensitive. If you are sick, they're going to detect that. Even something like these rapid SNAP tests that are coming out that use a little bit of blood, that are a lot cheaper and can get you a result a lot faster, they're still pretty sensitive. Coming out of around 97%, 84%, that's still pretty high. You're going to capture most of those people that are actually infected. Test specificity is the other side of the square, right? Test specificity is, all right, if I test a healthy person, how many times does that healthy person get reported as a healthy person, right? I don't want to say that a healthy person is sick. So what that actually is all of the people that are healthy divided by all of the that are told that they are healthy, divided by all of the people that are actually healthy. So what that looks like for this test is 12 out of 15 of them are given the correct value at the end of it. So this test specificity would be 80%. A pretty good specificity as far as tests go. Luckily, the coronavirus test actually has an even higher specificity. So this means that if you are given a result that you are sick from something like a PCR test or even some of those rapid antigen tests that use blood, you're pretty comfortable to say that you are actually sick. This means that false positives are exceedingly rare for PCR tests and these rapid antigen tests. There's a bunch of other tests that are kind of coming out, but the two that are most commonly used are these two. You've probably saw that Governor DeWine got a test and received a positive test when they were on their way to do a meet and greet, and they got a rapid antigen test that's a little bit less specific. Then they went and tried to confirm that infection by doing another test, and that test came back as negative. So it turns out that Governor DeWine was very likely a false positive. And that kind of shook a little bit of people's confidence in these tests, even though it really shouldn't have. It's going to happen, especially if you have someone that is probably getting a lot of tests, probably a couple times a week. Occasionally, you're going to end up with a positive sample if you're repeating that measure over and over again. We don't want false negatives and we don't want false positives to happen, but there's ways that we can design our testing strategies to try and limit the effect of those. Now that we've tested people and we know that someone is sick, we have an overall positivity rate. And that positivity rate is, okay, how many people that have been tested, how many of those tests report back positive? And if we have a high sensitivity and a high specificity, we can assume that a positive test is a sick person. The World Health Organization currently recommends 5% as the kind of what we should be aiming for during an active pandemic. Right now, there's many areas around the US that are hovering around 15. Florida has been above 25% for a while. Now they've gone a little bit down since then, but this is why Ohio is actually making travel recommendations based on this positivity rate. Generally, if you have 15% of tests coming back positive, you're either only testing people that are sick, which is not how you should design your surveys, or there's a lot of infection in your community. So neither of those is a good thing. You really want to keep that positivity rate down. This is Ohio's positivity rate over the last few months. Pretty stable over the last few months. We've been right at around July, we were around 5%, but it's gone down very, very slowly since then. So currently, Ohio has the pandemic under control, if not still kind of constantly burning in the background, kind of a slow smolder rather than this kind of big giant wildfire that we saw in other places. The other place that really is one of the worst that we could see is something that was happening in Florida, where 1 out of every 5 tests was getting reported as a positive sample. This is a sign that the infection was completely unchecked, and we had a very poor control on this infection in the initial stages of this, the outbreak in Florida, right? So Florida, Arizona, and Texas a couple weeks ago were really, really bad hotspots because of increases in testing and increases in control mitigation. They've now kind of brought the curve of that arc down again. When you're testing individuals, in the beginning of the outbreak, we didn't have a lot of testing capacity. We didn't have that many tests that we could do. So the way that we did it is we tested sick people, people that had those symptoms. Well, if you're someone that has flu-like symptoms that you are in the hospital for, there's a good chance that it could have been COVID in the beginning. So that's why, and when we had very small testing capacity, you had really high positivity rates. Some places were getting 70, 80% in early places in Washington or New York. If you are actually testing the entirety of the community and are doing a true semi-random sample, you're gonna get closer to what the true prevalence of infection is. We always want to test more. Testing more and getting more numbers out of this is always a good thing. It only helps us control infection better. That is all I have on like the epidemiology background of things. I'm going to get out of the way so you can see what other people are talking about. So next week we have Dr. Sin who's going to be talking. He's going to be talking about evolution and genetics, and we have other talkers on other topics coming up for the next few weeks. So I'm going to open things up for questions now. There's questions that you can type in chat. You can ask to be unmuted, and I can find you and unmute you if you'd like. I have a bunch more data that I cut and wanted to talk about. So we have a bunch more data if we wanted to get into it. If you have any questions, I'm more than happy to hang around and answer them. So yeah, thank you very much for coming to this. I'm going to hang around here for a little while. This is recorded if you'd like to share this at a later time. You should be able to talk in chat and ask questions if you'd like to. There should be a chat bubble on the bottom of your screen if you'd like to type in chat. Donna would like more data. Okay, here's some more data. There's a little bit more data. I think probably one of the more important sets of data that I didn't get the time to talk about was relative risk of death. I think this is something that is not discussed very well. When you're talking about relative risk of death, and if you say, hey, you're an 18-year-old, and what is your relative risk of death if you compare that to other groups? Someone that is under 18 has a lower risk of death, right? So their risk of death compared to that 18-year-old is something on the order of 16 times less likely. So it's a great thing that young kids are very unlikely to actually die from COVID. But you also have to kind of put things in perspective when you're talking about comparing something like a 49-year-old to an 18-year-old. The relative risk of death is actually 10 times greater. And I had to make another chart because it actually doesn't fit on the graph anymore, to the point that someone that is 85 years old actually has a 680 times the chance of death, of the relative risk of dying, compared to the 18-year-old, right? So we talk about this as being a age-related mortality, and it's certainly the case, but I think it's sometimes stark to see how big these differences are. Harold and Melanie wanted to see where if they wanted to see these graphs. A couple of these are graphs that I've made. A couple of these graphs are from places elsewhere. You're more than welcome to have a copy of the PowerPoint. I don't know where we would host that, but we can figure out where we might want to host it at. Yeah, so there's a couple. Jennifer has said, how safe are you inside versus outside? Inside, aerosols, those really small water droplets that are more likely to hang around for a long period of time, are much more likely to hang out and kind of be in the air. Anytime that you have more airflow moving through an area, that's going to knock those aerosols out of your range a lot faster. I would try and avoid indoor spaces as much as you can. Always masked, always for as limited amount of time as you can, right? That's the current CDC recommendations. Jennifer asked, you mentioned earlier that library books are not a common pathway. Does that apply to other high contact surfaces? What that data is coming from is basically you can test and say, have someone that is infected cough on a book, right? Or cough on a door handle, and then wait a few hours, wait a few days, or apply a cleaning product to it to try and see if we can clean that area. Shared surfaces are estimated to be really rare forms of getting sick. 95% plus of the people that get sick are getting it because someone else is speaking around them, and they're inhaling or getting into their eyes or mucous membranes. You are able to get sick. When I go outside, I don't touch my face. I pretend as if I'm wearing gloves that have feces on them. That's my experience. I have a lot of fecal work that I do. I pretend that I'm really dirty hands, so I don't touch my eyes or face or anything. Is there data on the effectiveness of IV treatment of air in indoor venues, as in like ultraviolet waves, Margaret? As in like filtering the air? Is that what you mean? Whether that's the answer or not, no, there's not a lot of good data. This is everybody's first attempt at learning about COVID-19, right? It's the first time it's come around. There's some lessons that we can pull from things like SARS-CoV-2, right? Where we are, or SARS-CoV-1, the thing that caused SARS. There's some things that we can learn from MERS, right? A very similar coronavirus that came out of Saudi Arabia called Middle Eastern Respiratory Syndrome. We take a little bit of our knowledge from previous things and kind of guess and extrapolate that out to this data. There's not, I can't really say one way or the other what's a good idea about filtering inside. The more air movement, the better. Sunlight seems to be a pretty good way to break it down as well. The CDC had some recent comments about 94% of deaths having comorbidities. Yes, that is something that I think has been, unfortunately, really misinterpreted a lot. I have a little thing on 6%. It started to be arguments that in fact, the reality of people that have that have actually died from coronavirus is 6% of the total reported cases, right? This is something that's going around on social media right now. In reality, this just has to do with reporting and epidemiology and public health that unfortunately it's getting misinterpreted by people that don't have the understanding and experience of working with these sorts of figures. This 6% figure is mostly coming from the fact that a death certificate only has COVID as the cause. And to say that someone that dies from kidney failure because COVID shut down their lungs and so their kidneys failed, which is your kidneys and lungs are actually connected in many ways, or if you have someone that dies from a heart attack because they have COVID, to say that that person didn't die from COVID, they died from a heart attack is inaccurate, right? They're actually dying because of COVID. HIV does not cause people to die. HIV causes people's immune systems to shut down, and then those people's immune systems can't protect them anymore, and they get killed by the flu, they get killed by cancer, they get killed by a fungus, right? Something they would have beat otherwise. But to say that like HIV doesn't kill people is just really inaccurate. It's kind of that same sort of inappropriate understanding of what's the cause of a disease, right? Comorbidities, things like hypertension, diabetes, heart disease, COPD, which is like emphysema and asthma and that sort of stuff, those increase your risk. Age increases your risk. There's pretty good evidence right now that age is a comorbidity, right? And there's evidence that having previous heart failure issues, having obesity increases the risk of dying from COVID. If you get sick from it, you have a 50% more likely to die from COVID because of obesity, right? That's a comorbidity. If you have two things at the same time, it increases the damage that both can do. Yeah, so that's something that just is coming out relatively recently. Yeah, thank you. Arizona and Florida were really bad a few weeks ago. This is kind of the current picture of where is getting worse and what's getting better, right? Ohio is still slow burning. This is per capita cases, so this is cases per 100,000 people. Florida was really bad, but now it's gotten better. So Florida and the infections, the outbreaks that were starting in California and New York, all of those has kind of gone around. And what we're really seeing now with the broad pattern of COVID moving around the country is we're really seeing like different fires starting in different places around the US, right? Countries that had really well under control, now you're starting to see fires popping up and infections popping up in areas. So South Dakota is getting pretty bad pretty quickly, right? So that's probably on the chart to be the next big outbreak center. India is very much on the big outbreak. They're reporting more new daily cases than most countries have had the entire outbreak, right? So just because you didn't have an infection previously is not necessarily that place is going to be safe forever. Becky asked if there's any evidence of the virus mutating. There is some evidence of like slight shifts in the disease itself, the virus itself. Most viruses, as they kind of age, as they start to kind of enter into the older, as they go through more time, most viruses get less severe. Most viruses, the mortality goes down simply because it's a really bad idea as a virus to kill your host, right? So viruses that kill their hosts really rapidly almost always burn out. Think Ebola, right? Ebola has very little risk of spreading outside of some of the clustered areas that it comes from because the people that get sick are so sick that they die rapidly and can't spread the virus faster. Could China have better contained the virus? Dennis asked. Probably not. There's some evidence that reporting didn't happen the way that it should, right? China is supposed to be reporting this stuff to WHO, and there's some evidence that maybe they could have reported it a little bit earlier. But honestly, China's response was so outsized, so rapidly, they actually probably would have done better than most other countries, just because they can do that kind of rapid government intervention. They have a very large government state. Ryan asked, my best guess, the fall will be bad. I'm thinking the swine flu pandemic 10 years ago. It's hard to say. No, we have only gone through one season so far with COVID. As more people move indoors, hopefully that will mean that we have less contacts between people. But if we kind of relax our social distancing policies and we're indoors, that's kind of a double whammy of negative things. As schools reopen and as especially in like high schools where there's pretty good evidence that high schoolers are very less likely to get sick, but they're just as likely to spread pathogen. So that seems like a really good combination of ways to kind of start the pandemic up again, burning pretty quickly. How can we be confident that a vaccine, given that viruses mutate? I'm not a virologist, I'm an epidemiologist, but luckily, coronaviruses are actually really stable compared to most viruses. Think like the flu, you have to get a new flu shot every year, right? Or sometimes within a season, right? Because there's mutations, there's a lot of different strains. Coronaviruses actually have proteins contained within the virion itself that their job is to correct DNA errors. Their job is to correct those mutations. So coronaviruses compared to other things are actually really, really stable. There is, I saw a graph, I don't have it here, but there is basically more genetic diversity within a single person that was infected with influenza compared to all of the coronavirus so far that we've done genetic testing on, right? So there's enormous variation even within a single person. There's lots and lots of mutations and stuff like flu, which makes it less likely that vaccines work as well as we want them to. Is there a possibility of detecting COVID-19 if you have had it earlier and it was not diagnosed? Yes, if you are someone that still has active virus, the PCR test picks up little snippets of DNA, and if you have COVID DNA floating around, that means you're still at least a little infected. But there's antibody tests that you can do that actually specifically only pick up infections that have kind of almost all the way ended or had ended weeks ago. In the news it mentioned, Jennifer says, in the news it mentions that COVID-19 affects the Black community at higher rates than the white community. People are saying that it's because the Black community mostly high risk with chronic disease and unheard, miscommunicated health on public health messages. What is your insights and data on that? Mortality rate is higher for the Black community. It is a little bit higher for the Latino community compared to other places. Mostly that has to do with if you're from a lower socioeconomic class, there's generally not a lot of evidence. There's genetic influences on this, right? So like ethnic groups, we don't think plays any role in this. We think this mostly has to do with socioeconomic status. So if you are somebody that is of a lower socioeconomic status, you can't skip work, right? Because you got to go to work. You're generally in types of employment that are more public facing, right? If you're someone that is working as a cashier at Kroger or whatnot, then you're interfacing with a lot more people every day than somebody that is, I don't know, working my job, right? I can stay home, I can do Zoom talks, I can do that sort of work, right? So it mostly has to do with their ability to get the virus. And then if they already get it, there's pretty high rates of cardiovascular disease in the Black community. So part of that has to do with racial discrimination and racist different exposures to health access. So that is the big major driver for that reason that we're seeing in mortality differences. Catherine says, is there a lot of different strains of the virus, some more harmful than others? Not a lot of evidence right now that I've seen showing that there's big strain differences. There's some mild mutation differences, but like we said, SARS-CoV-2, the virus that causes coronavirus, this COVID disease, tends to be fairly stable. If you'd like to hear more about different strains of pathogen, feel free to hang around next week where Dr. Sin is going to be talking about on the evolution of the virus over time. Yep, there you go. Dr. Sin is going to talk about genetic diversity in populations next week. I think I got everybody. I don't think I missed any questions. Like I talked about, this is the current RT trend. So this is the current reproductive number for different areas. This is the current trend, or the thing on top that you're seeing right here, where South Dakota is real bad, Iowa is real bad, North Dakota, Hawaii are all trending towards negative. They're getting worse. Whereas places like Missouri, Arizona, Texas, Rhode Island, Florida, Ohio, right, are here on the good end of things. Ohio is not the same population as Michigan, which is not the same population as Pennsylvania, right? We are close and we are heavily connected, but really what we should be thinking about with these sorts of pathogens as they move around is how they're moving around into different clusters, right? What the current trend is today, the thing that you're seeing up here on the top with the reproductive number, actually has very little relationship to what the data 3 months ago was saying, right? Arizona was really bad, right? Now it's great. Hawaii was not great. It's still not great. Minnesota and North Dakota were actually doing quite well 3 months ago. Now they're starting to trend negative, right? So it's not so much as, is this area better or is this area worse, but what is currently happening in a local environment. We could be having a relatively large outbreak in other small campuses around Central Ohio, right? A lot of other places publish their data. Denison doesn't publish their data, but places like Ohio Wesleyan and Ohio State do, and we're seeing pretty big differences in the positivity rate between places, right? Oh, Otterbein is not the same thing as Ohio State is. Ohio State is not the same thing as Ohio Wesleyan or Denison, right? These other colleges around here, they're different clusters of communities. So we'll know in a few weeks how things are going. I think that was all the data. Estimates on Ohio is that currently around 8% of Ohio has been infected at some point. So this is people that were infected early in infection, as well as people that are currently infected. Just based on the trend of infection. You can always find data from the Ohio State. The government puts out these Ohio Public Health Advisory System, which is a really nice and clear way to kind of tell you what's going on in any individual community. You can just find us on Ohio's COVID dashboard. They tell you exactly what the pattern is for stuff like emergency department visits, things like new cases. Luckily, Franklin County has had new cases going down every day for the last couple weeks, so it's really great. So luckily, we're no longer, I think we're class 2 currently. We previously were level 3. So we actually are seeing some positive changes as the outbreak abates a little bit in Franklin County. And yeah, I think that's all the data that I had. If there's any other questions, I can hang around for a bit, but I just wanted to thanks for coming. We're going to have more next week for you. Dr. Sin's going to come in and talk about genetics. Okay, thanks everybody. I'm going to stop this recording.